So we're gonna do cardiac radiology. This is coming. The information is coming from the USMLE content list, actually. So I follow that content list, and which is a list of diseases that medical students are expected to know when they graduate medical school. So that's the list that I'm following, and we're going to follow this outline. We'll do a quiz first, which is separate from the quiz that you've already taken. Review normal structures, and then go through the infection, neoplasms, ischemic heart disease, cardiomyopathies, valves, and congenital diseases. Okay, so we'll start off with a quiz. What do you think? Which vessel is this? You can just shout it out, or if you want to text it, that's fine too. LAD, okay. Everyone agrees? Perfect. And what chamber is this? So this is we call it cardiac CT, and it's optimized to look at the cardiac structures. Good. And then what valves communicate between the right atrium and right ventricle? Good. And how do you know it's the right versus the left? Yeah, right. The left is the pump, so the wall is thicker. Also the location. It's close to the sternum. Yes, that's exactly right. So what is this? What structure is this here? That is the ascending. So this is, yeah, so aortic valve. This is the left ventricular outflow tract, and it's right next to the mitral valve. And what are the muscles that attach the chordae tendineae to the mitral valve? What are these little muscles called? So yeah, this is the papillary muscle, and you have the chordae tendineae. So what happens when you have a papillary muscle rupture, say with coronary artery disease, acute coronary syndrome? Yes, why? Yeah, exactly. So the chordae tendineae, you no longer have that attachment here, so it's sort of loose and it's just regurgitating. And so we'll see some examples of that. Okay, and what are these vessels here that drain into the left atrium? There's 4 of them, paired, 2 on each side. Pulmonary veins, good. Okay, this type of endocarditis usually involves strep viridans. It usually has smaller vegetations, and it's typically a sequelae of dental procedures. What kind of endocarditis? What are the 2 different types of endocarditis? Any thoughts, guesses? Subacute, okay, good. And what is the other? So that's the answer, subacute. And what is the other type? Which is classically we see with like IV drug users, patients, they have like staph aureus and they're very acutely sick. Good. Good. What is the most common cardiac malignancy? Oh, true or false? Most common cardiac malignancy is metastases. True or false? False. Good. Oh, okay, we'll get to that actually. What is the most common cause of myocarditis? Okay, what arrow? The arrow demonstrates what? So what ventricle is this? We said left, and then we said this is the ascending aorta. Here are the aortic valve, and here's the, good. And what's going on with the mitral valves? Are they normal? Are they coapting? Are they touching each other? Regurgitation, okay. What is the problem here? So this is a cardiac cine that I took from YouTube. Here's the user. So what do you see here? This is a cardiac cine, MR. This is part of the MRI protocol for the heart. What do you see here? What kind of regurgitation? Tricuspid, aortic, mitral, tricuspid. Okay, so then Kathy thinks it's mitral. Call it thinks it's mitral. Okay, and why do you say it's regurgitation? What are you seeing here that you shouldn't be seeing? So this is diastole, it fills, and then there's systole. Backflow, yeah, there's this jet, right? And that jet is pointing in the right pulmonary vein right here. So when you see patients who have acute MI that have mitral regurgitation and you get this jet, they get acute pulmonary edema on the right side. And it's usually on the right side because of this jet, which is going to the right side. Okay. When do we see left ventricular free wall rupture after MI? 1 to 3 days, 3 to 5 days, 5 to 7 days, 7 to 14 days. C? Okay, so we think 5 to 7 days. Okay. What is the most common cardiomyopathy? Dilated, hypertrophic, restrictive, left ventricular non-compaction, right ventricular dysplasia. B, okay, so we think hypertrophic. Everyone agrees? Madeline thinks it's dilated, okay. A, any other guess? Colin said D, right ventricular dysplasia, okay. Oh, the exam shows what? So this is another cardiac snake. So here is the left ventricle, the left atrium, and then this is the aortic valve, right there. So what do you see here? Good. And why do you see that? So when it in systole, you're supposed to see a nice outflow, but instead, what do you see? Yeah, correct, exactly. Very perceptive. It's not opening very well, and you see this little white signal. That's like a jet because it's like trying. When you have a water pipe and you pinch the tip with your finger, and then the remaining opened water pipe, usually for the squirt, the jet. That's what you're seeing here. It's so narrow that as it pumps out, it's just coming at a high pressure. True or false? Right to left shunts causes late cyanosis. Right to left shunts causes late cyanosis. True or false? False. Okay. What does it cause? Immediate cyanosis. Okay. Which congenital syndrome can lead to bicuspid aortic valve and coarctation of the aorta? This is Turner. Okay. Everyone thinks it's Turner. Good. Okay, so this is the anatomy of the coronary. So there's sort of separate, when we think about the heart, different structures. First, the vessels, the valves, the heart, and then the pericardium. Okay, so we'll go through each of those. So there are 3 main coronary arteries, right, left, which then bifurcates into the LAD and the circumflex. We'll see some of the CT images, but the left anterior comes anteriorly and goes to the septum and anterior wall of the ventricle. The PDA comes off of the RCA 85% of the time, and then in a minor time it can either come from the left or it can be shared. So the nodes are supplied by the RCA. So if you have an RCA infarct, then you have arrhythmias and nodal issues, heart blocks, bradycardia. The coronary occlusion most commonly happens in the left anterior descending. That's the big one. That's coming down and supplying the anterior ventricle and also part of the septum. And this is what can lead to papillary muscle rupture, which can then you can get acute mitral valve regurgitation, edema, and the patient can become compromised. Chambers, so we reviewed this. So here's the right and the left, and here the LAD comes, It's usually here. There's an LED groove. And then the RCA sort of comes around the back. The circumflex. But we need to. This is a little high, so when the heart comes more inferior, then we can see the vessels better. So if you have patients who have big left heart, left atrial enlargement, it can compress the esophagus and can cause dysphagia, and also sort of cardiomegaly can lead to compression of the recurrent laryngeal nerve and cause hoarseness. The valves that we have, the main ones that are usually affected are the aortic valve and then the mitral valve. But we also have tricuspid and pulmonary, but I think the more common pathology that we typically see is with mitral and aortic. The aortic valve has how many leaflets? Good. So you have right and left coronary cusp, and then you have the non-coronary cusp. Some people just have 2 leaflets. It's called bicuspid, and that can increase risk of aortic stenosis later on. And then this is the mitral valve that we're going to talk more about. So the first part of that USMLE content list is infection. So we're going to start off with infective endocarditis. This is a, what kind of study is this? Good, so it's an echo, cardiac echo, and we're seeing which chamber? So the muscles are thick. So it's LV, right? So what valve is this? And is it normal? Good. So there's mitral agitation. And this is a CT scan of the chest, and you see this opacity with ground glass halo. And that, in the setting of a patient with infective endocarditis, is septic emboli. So septic emboli, I'm really impressed if people ever see this in clinical practice. But they get these like little small round patches, and then these subungual petechiae. I imagine probably patients are infective and they have cardiac signs and symptoms. There's 2 types: acute, that we typically see with staph aureus, and they get large vegetations, rapid, and then subacute, which is seen with dental procedures with oral flora, strep viridans. So yes, the type of so subacute presents with low virulence, and they have we see that in patients with like bicuspid valves or patients with disease valves and after a dental procedure. This is called what kind of study is this? MRI, yeah. So this is an MRI, and yes, someone mentioned that it has contrast. MRA is different from MRI with contrast. So MRA looks at vessels. So this one we're looking at the heart. So the timing of the contrast is a little different. The view for this is the same view as the other. Knowing the views can be helpful, and so this is the CT scan, and this view is the same view as the view that we're going to see on the MRI, this one. Okay, so this is the aortic valve. This is the ventricle, left ventricle, which is thickened, and then so that's the view. So focus on the left ventricle here, and then this is the sort of the sagittal view, and this is the left ventricle here, which is thick wall. So let me get back to my presentation state so I can see your text chat box. Okay, in MRI, we can do a contrast-enhanced MRI, which is like a CT with contrast, except we're using gadolinium, not iodine. And patients, just when you have myocarditis, you have inflammation of the muscles. So it becomes hyperemic. It becomes, the signal increases. Just like if you had an infection, you would have more blood going to it. Same thing with the myocardium. So normal heart is dark, like this kind of dark. And when you have contrast, it makes it bright. So that's what we're seeing here. We see the myocardium becoming bright diffusely. So this is what you see with myocarditis. And there's different causes of myocarditis. Just like there's different causes of hepatitis, different causes of colitis. It's just a finding, but you have to work it out. And the pattern of the enhancement can sometimes help. So this is subepicardial, mid-myocardial. So the endocardium, the mid is involved. So you can help with the differential diagnosis. Here we see slightly different view of the heart, but we see a similar, there's enhancement here. There's bright spots here, and there's bright spots here. It's not homogeneously dark, which is what we typically see with normal myocardium. So this is what you see with myocarditis, and MRI can help with that. And the most common cause of myocarditis is viral. And here we see reactive pleural effusion. So CT is not very sensitive, to look at the myocardium, not in the same way that MRI is, but patients with myocarditis or pericarditis can get reactive pleural effusion. And that's what we're seeing here. So myocarditis most commonly is from infection, but there are other causes. Certain chemotherapies cause cardiomyopathy, radiation transplant, giant cell myocarditis, SLE are some of the causes. So correct, the most common cause of myocarditis is viral. Neoplasm. So this is a CT, and we see, what do we see? And in what chamber is the abnormality in? Is this normal left atrium, right atrium? Okay, so is this left atrium or right? So the pulmonary veins drain into which atrium? The left, right? So this is the mass in the left, the region of the left atrium by the interatrial septum here. So this is a typical place for a myxoma. And the problem, it's a benign tumor, but the problem is that it can get in the way of, right? Because it's right next to the mitral valve. So it can obstruct flow into the left ventricle. So it's really just the ball valve effect that it has, which can lead to syncopal episodes. So that's, here on the other hand is a mass, and this is, unlike the myxoma, which has a nice round appearance and look very homogeneous, this one is very ugly looking, it's heterogeneous, thick walled, and it's also crossing multiple compartments. So this is METs, cardiac METs, and cardiac METs are the most common cardiac tumors, 30 to 1 compared to primary. Just because the prevalence of cancer, non-cardiac cancer, is so much more common. So you just are more likely to see a cardiac METs than a primary cardiac lesion or cancer. So this is true. Most common cardiac malignancy is metastases. Okay, now we're going to talk about valves. So we talked a little bit about coronary arteries. We'll talk some more about it. We did a little bit of myocardium. And let's talk about a little bit of the valves. So we said that we have the mitral valve, and the chordae tendineae are attached to the papillary muscles. And this is important because if you have papillary muscle rupture, then you can get acute regurgitation. This is cardiac. So you can see the LVOT, left ventricular outflow tract. And this is the septum, interventricular septum. So things that can obstruct the outflow tract, and we'll talk about, both primary valvular disease as well as structural obstruction we'll review. But here you can see the chordae tendineae kind of well here, attached to the papillary muscles, and here are the the mitral valve. Here is an example of rupture. So this mitral valve is sort of like flailing because of a papillary muscle rupture, which can, be from a myocardial infarction. So that was the answer to this question, which I think most, if not everyone got right. So their congestive heart failure, is when you have, sort of the left ventricle, well, the entire heart's not really working, so you have backflow and back pressure, and that can go into the pulmonary venous system. And so what you get is, initially you sort of just get redistribution into the veins, and then over time, they can go into the interstitium and create these curly V lines when you have sort of fluid in the interstitium. And if it gets really bad, then it can go into the alveolar space and then go into the pleural space, and they get large pleural effusion. And so after diuresis, their acute CHF symptoms will improve. So you can have mitral valve. So this was an example of a myocardial infarction that led to a mitral valve regurgitation. And you see, the jet is going to the right pulmonary vein. This is why you see asymmetric right pulmonary edema in acute mitral regurg. Here's an echocardiogram version of mitral valve regurg. So this is the so small ventricle. This is the left ventricle. The muscles are thicker. This is the mitral valve leaflets, and here they're coacting, which is what it normally does. And patients with mitral valve prolapse, it doesn't coact, so you have regurgitations. So MR is actually better because you get flow dynamics, and you can see how it's compared to echo. You just get better structural as well as flow information compared to ultrasound. The problem here, so yes, I think most of you got this correctly, is there's a mitral regurg, and then you see just this regurgitation. And so ischemic heart disease, so here is we call this a coronary artery CT. So patients, this scan is optimized to look at the coronary arteries. They get a beta blocker to increase the flow to the coronary arteries. And so you're looking for, so the LAD is anterior. It's coming down the LAD groove right here between the right and left ventricle. And I'm going to play this multiple times, but in the proximal end, you see the contrast in it. But as you keep going, you lose the contrast, right? So this is consistent with an acute infarct. It's obstruction of the coronary arteries, which then leads to an infarction. So this one is a reconstruction. So we see, I wonder if I can get this out of the way. Oh, that's just the image as it is. Okay, so this one is a reconstruction. So we see this is the left main, and then this is the same patient. So you have the left LAD, and what do you see here at the LAD? So this is the LAD right here. What do you see? Is it a nice, beautiful, patent vessel? Athero, right? So you have both calcified and non-calcified atherosclerosis. Calcified is the high density stuff you see, and you have non-calcified, it's the soft atheroma as well. What else do you see? What is the yellow arrow pointing to? When we do the study, what we're trying to do is assess its patency. So we say if there's mild, moderate, severe stenosis, or if there's complete occlusion. So by looking at this, where did the contrast go? Yeah, exactly, where did the contrast go? So the contrast is here. We have a bunch of calcification, and it's gone. And then, I don't know, maybe there's a little trickle here. So what is this? So this is what happens with patients with vasculopathy. They have severe athero, it's like traffic, you take out one lane because it's under construction. You take out another lane because there's more construction. And then eventually you don't have very much lane left. And then, then you have a car accident and then you're done. The whole freeway is out. And that's what's happening here. The vessel is getting narrowed and narrowed. And eventually, just a little more narrow, and then you have critical stenosis, and then you have an acute MI. So when you have that critical stenosis, patients start to have unstable angina. The pain, chest pain doesn't get better with rest because they're going to have an impending major coronary event. So those are the people that can really be helped by percutaneous coronary stents or CABG. Here we have a patient who had an MI and then has asymmetric right pulmonary edema, again from the mitral regurgitation that then goes to the right vein, pulmonary vein. What is this study? MR, CT, ultrasound, Lexis scan. Okay, so this is a cardiac stress test, yeah. And what is a cardiac stress test? So this is the rest images on the bottom, and this is the stress images on the top. And these are different angles of the heart. So this is a longitudinal axis. That is the same as this view right there. Okay, so I'm just going to help you focus on that because that's the easiest. This is, we call it short axis, and that is the same view as that sagittal MRI view right here. That's a short axis, okay? So when do we do a stress test? On everyone? Why do we do a stress test? Negative markers, but EKG is abnormal. Yeah, so you're concerned about a coronary source and you want to know if it's if it has clinical impact. So patients are at rest, and then we evaluate the radiotracer distribution, and it should be homogeneous in all the myocardium. And then we have them exercise on the treadmill. And then, so now they're stressed, and so they're going to have increased demand to the heart. And then we acquire more images to assess. So, in patients who have moderate to severe atherosclerosis, when they're stressed, then they're going to have decreased perfusion to the vascular territory, compared to patients who have normal coronary arteries. And so if that's the case, then you know that this patient has CAD that can be fixed either with CABG, some revascularization. So it's helpful because then you can identify those patients. What if at rest you have no perfusion? Let's say the anterior wall of the left ventricle. Instead of seeing the nice black line here, it's just white, like the rest of the image here. What does that mean on the rest test? So the radiotracer goes to wherever there's flow, right? So if there's photopenic defect, that means yes, right, big MI, there's no flow going into it. So it's an infarct, it's a scar, it's dead myocardium, right? This is different from salvageable myocardium, which is, it's not dead yet, but it can become dead if that flow becomes completely obstructed. So that's how you can tell and differentiate, say, a scar, a dead part of the myocardium, from myocardium that's ischemic, right? That's low flow, but is still alive. It's not dead yet. So here we see the same views, but when the patient runs and are on the treadmill, this area becomes incredibly photopenic. So there's ischemia. There's ischemia because there's low flow to this. So this patient can benefit from revascularization. So the people who do not, so which group of patients will not benefit from revascularization. So the question is, was the previous black and white image normal? This one? Yes. So this is the normal stress test. At rest, there's normal radial tracer, and then at stress, the patient has normal flow response to stress, and so they vasodilate, and there's normal flow to feeding the myocardium. Here, in contrast, patient is running on the treadmill, and now this part is, demand ischemia, exactly. So this part, it becomes, you start to have ischemia because there's low flow to this area. So patients with this on imaging can then benefit from revascularization, CABG or coronary stents. Which patients will not benefit from revascularization? Any thoughts? Yeah, if you have an old infarct. So if the tissue is already dead from the get-go, you're not gonna save it, right? Because it's already dead. So that you can find that information out. And also the severity of it. So, they actually say if you have ischemia like this, like you assess the severity. So if it's more than 50% of the myocardium, then it's less likely to respond versus less than 50% of the myocardium. So you can risk stratify patients. We usually use the Framingham risk stratification score, which evaluates their diabetics, hypertension, age, gender, things like that, to assess their cardiac risk of a major cardiac event. The coronary artery calcification is another risk stratification tool, and it's a non-contrast CT. You can look at the calcifications in the 3 vessels, and then the software generates a number, like 0, meaning there's no calcification, to in excess of 500-600. So patients with high Agatston score, so that's called the coronary artery calcification score or Agatston score, they have patients with high Agatston score have an increased risk of a major cardiac event. So the American Cardiology Society, they issue this is their guidelines for the patient population who would benefit from this study, and basically patients who are intermediate risk, asymptomatic, because you're trying to risk stratify them and sort of treat them in advance. Low to intermediate risk who are asymptomatic. So it's like the low intermediate sort of asymptomatic group, or patients with risk factors, diabetes, older age, who are at increased risk. And one study showed that Agatston score was actually better than the Framingham cardiovascular risk calculator for predicting a major cardiac event. Okay, so people who do go on to get an acute MI have several problems, and it has to do with complications that result. We talked a lot about the mitral valve regurgitation, but actually the most common cause within death within the first day is arrhythmia. You just mess up that Purkinje fiber tract, and so they start going into VTAC. And unless there's some defibrillator around to restore their heart rhythm, and then that's acutely. And then within 1 to 3 days, they can start getting this reactive pericarditis. We learned this a lot for friction rub, but I wonder if anyone ever actually hears friction rub. And then papillary muscle rupture, which reviewed, occurs within a week, and then you can sort of go on to more severe complications depending on the size of the infarct. You get septal rupture, aneurysm formation, or the left ventricle, which can just blow out because the dead muscle becomes a weak area. Dressler syndrome happens weeks later, and it's an autoimmune response resulting in fibrinous pericarditis. So when do we see left ventricular free wall rupture? Good. The 5 to, you know, these things I have to like look up 5 to 14 days because I'm not a cardiologist. But yes, 5 to 14 days, and that is dangerous because it can lead to hemopericardium and then cardiac compromise. Immediately, the most important complication, cause of death, is arrhythmia. So here is a patient who has cardiac tamponade. So this is the heart, and this is the pericardium, and there's this large effusion. So pericardial effusion, and the density can help you clue into what kind of effusion it is. If it's low density, then you think about simple fluid. If it's intermediate or high density, then you think about what? Blood, yeah, hemopericardium, which is what you would be concerned about here because it is not low density simple fluid. Acute pericarditis, that's one complication of myocardium, but there's different causes. I mean, in the appropriate setting, it could be from MI, but it can be from viral as well and other causes, or idiopathic in most cases. So this is a left ventricle, and then here you have there's different layers of the pericardium, the visceral and parietal layer, and it's enhancing. So this is with contrast, gadolinium, and there's a little bit of effusion here between the visceral and the parietal. And so this is acute pericarditis. And as I said, there's different causes depending on the patient's clinical context. Uremia, so patients with ESRD can also develop pericardial radiation. No, we said MI already. Complications. Oh, here it is. Okay, so here is a ventricular fluid rupture. So this is the left ventricle right here, and if you go up, there's this sort of irregularity out here that's not normal, and so that's contrast. That's outside the normal left ventricle, and so this is cardiac rupture with a secondary pseudoaneurysm. So this isn't that incredible that they got this image? The patient probably died. So here is a 3D reconstruction of the pseudoaneurysm that developed after the left ventricle ruptured with an MI. So this, on the other hand, is the left ventricle is bulging here, and is thin, right? So that tells you that the patient had prior myocardium of the apex, cardiac apex, and then this non-enhancing thing is the clot. So patients who have infarct are at increased risk for developing clots because that part of the muscle is akinesia. There's akinesia, it's just not moving. And so when you have no flow, then you start to increase risk for clots. Dilated cardiomyopathy. Okay, so we're moving on to cardiomyopathies. Dilated cardiomyopathy is the most common cause, and it's often idiopathic or familial, but there's a bunch of other causes. Alcohol, beriberi, Coxsackie, doxorubicin toxicity, hemochromatosis. And this is what it looks like. So all the chambers are enlarged. The right, the left, the atria, they're all like enlarged. And in this patient, patients with chronic cardiomyopathy can start to get liver failure, and we start to see it here actually. I don't know how to pause this thing. Here. Dang it. Here you see a ginormous hepatic vein and IVC, so there's right heart failure, and the liver becomes very big, and there's backup of flow, and so as a result you get cardiac hepatopathy, which can lead to liver failure. So the most common cause of cardiomyopathy is dilated cardiomyopathy. Myocardium. Okay, so there's another type of cardiomyopathy called Takotsubo. This is on the USMLE content list, and this is, we said you can have various complication of the myocardium after MI. Here, this is a patient with normal coronary arteries, and so what you see here is you see this bulging of the left ventricle. This happens in the setting. Takotsubo stands for broken heart syndrome, or they call it because this is Japanese for broken heart. Patients who have a stressful separation, like a divorce, or a significant loss of a family member, they become very stressed, and they can have this event, Takotsubo cardiomyopathy, with normal coronary arteries. So a pristine coronary arteries, but it's really from stress, and it's transient. So patients, once they've recovered from their psychological stress, their heart returns to normal. But MRI can help with the diagnosis. Hypertrophic cardiomyopathy is another type of cardiomyopathy that happens in young people because it can lead to sudden death. There's a recent UCLA basketball player that was recently diagnosed with hypertrophic cardiomyopathy, and I think now has to stop playing. So here, the left ventricle is very thick. This is symmetrical hypertrophic cardiomyopathy because it's just diffusely sort of homogeneously thick. And but you can have asymmetric form of hypertrophic cardiomyopathy, which is what we see here. So here we have asymmetrically thickened septal ventricle muscle, and this is important because the left ventricular outflow tract is here, right? Those exit out the aorta. So it's sort of like that myxoma where you have a structural obstruction of the LVOT. And so this is why this is dangerous, because patients with this, if they have an acute demand, they're exercising or whatnot, and then their muscles start to contract, they can actually obstruct their outflow, and that's why they basically there's acute death. Restrictive cardiomyopathy is when you have, like, the muscles itself loses the normal elasticity. It's not able to expand and contract. It becomes really stiff, and that can be from a lot of different causes. You can have infiltrative causes like amyloid, sarcoid, lots of different causes, radiation, fibroelastosis. But that's restrictive because the normal myocardium is no longer has the same kind of plasticity or elasticity. This is, okay, we're doing a little bit more of the myocardium. And, I'm showing you, this is a MRI. So remember, we can look at the enhancement pattern of the MRI. So this is a normal left ventricle, and the myocardium is typically dark black like this. And when you give contrast, if you have increased hyperemia, it can start to look more gray because you have contrast that's going into the myocardium. So this is an example of myocarditis. And the symptoms will vary depending on the patient's underlying etiology. It can be asymptomatic, or this can lead to cardiogenic shock. We said, remember, viral is the most common cause, but it can also happen from MI, from other causes. So you can look at the MRI signal to then give, to diagnosis disease. So here we have subtle increased signal intensity, which is consistent with edema and hyperemia. Okay, so let's talk about pericardium. So we said there's like a visceral and parietal pericardium. This is what it looks like on CT. You have like a little bit of fat between the pericardium and the myocardium. And then on MRI, fat is white here, it's a T1. And then the pericardium is this dark line. And this is the myocardium. So this is, there's 3 layers: the fibrous, the parietal, visceral layer. We only really see the parietal layer. I mean, and maybe that's the only thing that, yeah. So we'll show you some examples. Here we have, what do you think here about the pericardium on the chest radiograph? Normal, abnormal? Restrictive cardiomyopathy, yeah. Why do you say restrictive cardiomyopathy? What are you seeing that is cluing you into that diagnosis? Yeah, there's extensive heavy calcification along the pericardium. And here's a CT scan of another case of a patient with pericardium, restrictive cardiomyopathy. And this time is not calcification. This was more, you have pleural thickening that can then cause restriction of the heart. And here there's acute pericarditis, and we have reactive effusion, which we classically see with pericarditis. More examples of effusion. Here is a patient who had surgery, and there's an asymmetric pericardial effusion here. This one is high density, so you think about hemopericardium, not just simple. And depending on the context, it could be from trauma, it could be from surgery, it could be from MI. Here we see, the pericardium should be nice and thin, but here's uber thick. So that tells you again it's pericarditis. In terms of the cause, again, these are just imaging findings, but can lead you to a differential diagnosis in terms of what is causing that finding. Okay, we're going to talk about valves. Here are chest radiograph, and based on the location, you can sort of figure out what valves are where. The pulmonary valve is the highest, but there's not really much that's done in that. It's usually the aorta and mitral valve. So the aortic valve is the next highest, the most cranial location. So we said already that mitral valve regurgitation can occur from infarct, but it can actually happen with rheumatic heart disease, dilated cardiomyopathy as well. And it's problematic because you have insufficient outflow because so much of the flow is regurgitating. And then eventually it leads to left ventricular failure, dilatation, and you get dilated cardiomyopathy and venous hypertension. So here, what do you see here on the chest radiograph? So lung volumes, no, normal. Is there any consolidations or pulmonary edema? Okay, and can you tell me more information? Is it pulmonary edema like typical CHF pulmonary edema? Or it's, yeah, so the right side is asymmetrically worse. Correct. And that's because the patient had an acute regurgitation from an MI with that jet that goes into the right side, leading to the right pulmonary edema. Okay, but you can get stenosis too. So stenosis typically come from rheumatic fever, and the valves just get really stiff. And so we call this like the double density sign because the left atrium is so big, it creates this double density on the radiograph. And the pulmonary artery gets really big because you have right heart pressures. And another type of stenosis we see is with aortic stenosis most commonly is from just aging athero with heavy calcifications on the valve that restricts its movement. And if it becomes critical stenosis, then patients can get TAVR. So we'll talk about TAVR in a sec. So this is that study that we saw initially, which is showing an aortic valve stenosis. Complications of, I guess we don't have TAVR here, but do you guys know about TAVR? So TAVR is a way to treat aortic valve stenosis and to percutaneously. So before, if patients had critical aortic valve stenosis, they had to undergo an open heart surgery and have their aortic valve replaced. But now we have transcatheter aortic valve replacement, which is less morbid, and so they have an endovascular approach with a sheath, and then they put a balloon all the way up into the aortic valve. They plasty it open, and then once it's plastied, then they put the artificial valve percutaneously across the area of the aortic valve. This is really cool because, it's a percutaneous procedure, so patients, just outcomes are the patients don't have an open heart surgery. I mean, the one case of aortic valve stenosis operation that I saw when I was a general surgery resident, they died. So it's a very morbid operation. So this is, a great way to have the same outcome with less morbidity. And that's the beautiful thing about interventional radiology. That's done by cardiologists, but I hope you guys appreciated some of the cool things that interventional radiology can do with Dr. Liu and Dr. Song's lectures that you all had. Okay, let's talk about artificial valves. So once you have a TAVR, but that can be, the valves can be either mechanical or bioprosthetics. Mechanical valves last longer than bioprosthetics, but they require anticoagulation. And all valves are MR compatible. There's a lot of different complications, structural complications as infection and leaks and thrombosis. So, but now with percutaneous options, there's increased utilization of these TAVRs over open heart surgery. Okay, let's talk about congenital heart disease. It's 4 o'clock. Do you guys want to take a break, or shall we keep going? Any preferences? I think we probably have 25 minutes more, maybe 30. Keep going? Okay. Does anyone object? I'll take that as a no. Okay. So let's talk about congenital disorders. You've got the right to left and then the left to right shunts. Remember, the right side is non-oxygenated blood. The left side is oxygenated blood. So on a right to left, you're going from non-oxygenated to the left side, which is pumping out to the rest of the body. And this is why you get early cyanosis, because you have a lot of non-oxygenated blood eventually getting pumped out. In contrast, the left to right, you have oxygenated blood that goes to the right side. You get late cyanosis, and this typically happens after compensatory mechanisms. The most common cause for left to right is a VSD, and that's kind of cool because you can now repair that also percutaneously and put an Amplatz valve across the VSD instead of, again, open heart surgery. The right to left stuff we typically see with children. These are truncus arteriosus, where instead of having the pulmonary artery and aorta, you just have one trunk. Transposition, where the two vessels are switched congenitally. Tricuspid atresia, where you basically have one ventricle. Tetralogy of Fallot, we'll talk about in a total anomalous pulmonary vein return, where the pulmonary veins, instead of going to the left atrium, don't go into the left atrium and then comes back into the right heart system. I'll show you an example. So, true or false, right to left causes late cyanosis. That's false. That's early cyanosis. So this is a persistent truncus arteriosus. Normally the aorta and the main pulmonary artery should be two separate trunks, but here they share a common trunk. And they have to have a VSD because you need the blood to mix, otherwise it's a non-viable structural deformity. In contrast, transposition, So normally, we said the left ventricle, you get the aorta, but here you get the pulmonary artery because they're switched. This is also not viable if not recognized early and corrected. Tetralogy of Fallot, it's PROV, so you get these 4 findings, and it actually has to do with this coronal septum. So the coronal septum is this part of the interventricular septum, and this part is in the wrong place. So it moved anteriorly and superiorly. And that wrong location causes the pulmonary artery to become very narrow. So that's what leads to the 4 findings we typically see. So the conus, it's like in the wrong place. So first, the pulmonary artery becomes like really narrow, so you get pulmonary atresia. And then you have right ventricular hypertrophy because now the right heart has to pump against that narrowed outlet. And then you need the VSD to have like the mixing of the blood. And then the overriding aorta, that means the aorta is displaced this way between the the 2 ventricles. So that's what the overriding aorta is. So, but it all comes from like this mallocated conal septum. Okay, and then last, sort of right to left shunt is called total anomalous pulmonary venous return. So we said normally the pulmonary veins empty into the left ventricle, and there's 4 of them, right? You get paired ones on right and left. In patients with TAPVR, you don't have that. So, okay, so normally, like we said, it goes into the the atrium. But patients with TAPVR, it communicates here, and there's this vessel that gets then dumped into the right atrium. So there's no venous return into the left atrium. Okay, so that's also not, that also causes the right to left shunt. And patients usually have a VSD, otherwise the patient's, it's a non-viable structural deformity. Epstein's anomaly, that's when you have, so the tricuspid is in the wrong location. So normally the tricuspid is here, but in Epstein's anomaly is a congenital problem. It's sort of lower down, so the ventricle becomes very, very small, and so it sort of becomes a non-functional equivalent, and then the atrium becomes very, they call this atrialization of the left ventricle because the valves are in the wrong place. Okay, so now left to right shunts, we said is mixing of oxygenated to non-oxygenated, so you get late cyanosis typically because after they have compensatory Eisenmenger syndrome, most commonly due to VSD, and they may not be identified at birth because it's mixed blood, but over time the right heart becomes bigger, and then that can then lead to right heart failure. So here is an atrial septal defect. So this is right and left atrium, and here there's no septum separating those 2. Another cause of left to right shunting. Here is, so the patent, the ductus arteriosus is the congenital tract. Typically that closes off after the child is born, but some patients can have persistent, so you get mixing of left to right blood, and then over time that can lead to right heart failure if uncorrected. Eisenmenger syndrome is sort of the late sequelae of unrecognized left to right shunts, because over time the right ventricle becomes enlarged, and then they start to get late cyanosis, clubbing, polycythemia, depending on the severity and the chronicity. Coarctation of the aorta, this is when you have narrowing at the ductus arteriosus, the juxtaductal area, and this can lead to scalloping of the ribs because the internal artery, the collateral vessels become really big, and so then there's the typical arterialized flow, and then that can cause scalloping of the rib underneath it. Congenital cardiac defect associated with alcohol, maternal infection, Down syndrome, diabetic, and Marfan syndrome. So bicuspid aorta, I think most of you guys answered this already, was Turner syndrome. And that's it. Question.